Can we start?
Yeah, I think we are at 7:30. If you allow, shall we start?
कल में क्या सेगा 100% होनी चाहिए ना डी डाइमर से लेके तो मैं ताई
Okay, so we shall start with your permission, sir. So good evening and thank you very much all of you for joining in, and thank you Dr. Rajat for sparing your time for this very well awaited sessions on ECG drill and practice. It's my pleasure to introduce today's speaker, Dr. Rajat Sharma, and I'm sure you all know him personally and professionally, but I'll have a customary of introduction. Dr. Rajat Sharma, who is a certified electrophysiologist and fellowship in ESC, HRS, and American College of Cardiology. He has been trained and got his advanced fellowship in electrophysiology from Queen Elizabeth Royal Infirmary, Canada, and then he got advanced electrophysiology from UCLA, and he fortunately is again from one of the local institute, PGI Chandigarh, pass out the postgraduate, and he's currently working in Fortis Hospital, Mohali. All of you are well interested in that. And as we know, Dr. Rajat has a great interest in ECG, of course, being cardiac electrophysiologist, but then he has great interest in the congenital diseases and especially sudden cardiac arrest and the complex arrhythmia ablation devices, and he's expert in doing that. I'm sure we all will have fun and a great learning during this session. It is a group I think we can afford to have discussion and interaction as well. I take this liberty on behalf of Dr. Rajat that you can even open up your line and be interactive through chat. And I'm sure we'll have a great session. Over to you, Dr. Rajat. Thank you very much. And over to you, Dr. Rajat.
Thank you, Tender, for that nice introduction, and welcome all the audience. And in fact, I was actually dying for this particular day because I had conceptualized this particular module long back, but because of some or other problem, we never had the opportunity to actually sit together and discuss, because I know this is one of the area in clinical medicine, whether it is cardiology or internal medicine. It is an exciting tool actually to really go deep into the patient's problem. So I see an ECG is an excellent tool where you can actually make a lot of sense. Just if I'll talk something, just an hour back, I saw a patient who actually was diagnosed as an acute anterior valve, but it was actually a flecainide toxicity. So based on the ECG, you can make a lot of diagnosis. So I wish many physicians who are actually dealing with internal medicine, they should have a decent knowledge. It is not a very, very big science actually. If you have a very streamlined thinking and analysis power, probably you can actually make a meaningful diagnosis from the ECG. Because at times, when we look at an ECG, we may miss so many things. We try to wrongly interpret some of the things as something else, and then we start making mistakes. So in this particular ECG drills and practices, we have a couple of modules. So these modules will be every monthly, and the last Thursday we are having it. And first we'll talk about the bradyarrhythmias.
Recording in progress.
And we will go for the next module called the blocks. Blocks means the kind of vesicular blocks or bundle branch blocks, those blocks. And then subsequently we'll talk about the tachyarrhythmias. Then we'll talk briefly on the fourth module on the sudden cardiac death. There we'll talk about the various channelopathies, various kind of VTs, VFs, and other diseases like Brugada and all. And lastly, we'll have a short discussion on coronary artery disease, various kind of dyselectrolytemia, drug toxicity, and followed by a pacemaker. Then subsequently, on the Christmas Eve, I'm planning, if I have a discussion with the abbot, and we can possibly have an assessment on the day last, that will be an exciting thing to do, so that we can actually know how much we have learned from this 4 or 5 modules. So to start with that, let us come to the first part of that thing called bradyarrhythmias. As we know, we have a very streamlined conducting system starting from the SA node, which is anatomically situated in the epicondyle surface of the right atrium and the SVC junction, which is connected by more than many internodal pathways and conducted electrical rhythm to the AV node, which is situated septally just above the coronary sinus in the both the interseptal septum. Then the bundle of Haze and goes down as bundle branch. So we are not going to discuss the detail about an ECG like the P waves and other thing, because if we start discussing all those things, it's going to be a very, very lengthy topic. So we'll start with the silence around the SA node. That means we'll be discussing the SA nodal pathologies and the ECG corroboration of those findings. Now look at this patient. He is a pretty young boy who came to the heart rhythm clinic with a recent history of syncope. He is an absolutely healthy chap, never had any kind of past history, except he had similar episodes of pass out during one bout of acute appendicitis. So now the 12-lead ECG is given to you like this. If you look at the PR interval, so in the first 2 beats, it is 124. Then what happens in the third beat? It is increased. So out of all the 4 options, what do you think about the possible mechanism of the heart block? Then if you look at the PR interval in the third beat, it is prolonged to 220 millisecond. And if you look at the RR interval, it was 104, 120, and then it is significantly prolonged. And there is a missed beat. The P wave did not conduct. What do you think? This P wave came in the right time, or it was slightly prolonged? It definitely is slightly prolonged than the possible preceding PR interval. So here we are having a situation where the AV nodal conduction and the SA nodal conduction both are affected simultaneously. So this cannot happen because of a AV nodal block or because of an isolated SA nodal block. So there has to be something which is commonly affecting both the AV nodal conduction as well as the SA nodal conduction. So what is the possibility? It has to be something which is the innervation is getting affected, that is commonly seen in vagal reactions. So this boy, when he used to have some kind of acute abdomen or acute pain, he used to have such kind of AV nodal and SA nodal dysfunction commonly seen in vagal reactions. Then once this vagal reaction is over, or automatically the PR interval in the last bit has normalized to 124. Now coming to, and this is a very common kind of ECG that you'll come across in the pre-assessment clinic when you are an anesthetist just trying to figure out the patients coming in for the surgeries or when you are there in the ER. Now, this is another middle-aged gentleman who was referred to the heart rhythm clinic from the PAC clinic during a follow-up for an elective gallbladder surgery. This guy is healthy, non-hypertensive and a non-diabetic individual. He enjoys a completely good health. He denies any kind of dizziness or palpitation in the past. But the cunning anesthetist, she insists some clarity on the ECG that she came across, and she sent it to me. Now, if you look at here, any kind of clues that you are having. Definitely, there are some beats which are coming together, and in the middle, there is, let me just put my cursor. So here, if you look at the PR interval and the RR interval were quite regular, and here the RR increased and it increased longer, then probably here it is normalized. So in between there is a PR and the RR are quite regular, and in between there is some kind of delay or prolongation of the RR interval, right?
Yeah.
Yeah. So if you look at here, the PR interval here it is 640, 640, then suddenly the PP interval prolonged. So there is a constant PR interval. That means there is no Venky backing in the AV node or no AB, Mobius AB block. And if you look at the variation of the PP interval, here it was 640, 640, then it suddenly prolonged to 1040. So in such kind of situation, when there is a prolongation of the PP interval of more than 140 millisecond and more than 120 millisecond, and if you notice that the PP interval is gradually lengthening or shortening in a cyclical fashion, and if you have an ECG corroboration, then probably you can identify those things as a sinus arrhythmia. So when you are having some kind of slowing of the rate and normalization of the rate, then you must insist whether this has got some kind of respiratory relationship or not. But minded, this is a middle-aged person. So this person should not have any kind of sinus arrhythmia, because sinus arrhythmia that disappears over a period of time. So when you are dealing with the sinus arrhythmia in an elderly population, or this arrhythmia, sinus arrhythmia is a non-respiratory, then probably you are dealing with some kind of nodal disease. So when you are looking at an ECG like this, it may look benign completely, but you need to ask the patient whether he has symptoms if the patient is elderly. If the patient is quite young, then it is a possibility. So sinus arrhythmia, you will have a normal PR interval. There will be gradual lengthening or shortening of the PP interval, and whenever there will be an increase in the PP interval during expiration, it will be more than 120 milliseconds. Now coming to the third case, she is an elderly female. She presented to the heart rhythm clinic for evaluation of palpitation for a couple of months. C feels occasional skip beats and choking sensation in the throat. She is an hypertensive and a diabetic, but enjoys a good health. D again denies any kind of dizziness, palpitation. She is taking CCBs, ARBs, and beta blocker for her hypertension, and the ECG looks like this. So, what do you think about this? So, here is a situation where we have a similar pattern where we have the normal PP coming in between with a constant PR of 120 millisecond. And if you look at the subsequent PP interval, it is 640 in the next 4 PP interval, then suddenly it jumped out to 120 millisecond. So 1280 milliseconds. So it is exactly the doubling of the PP interval. So we missed a P wave in between. So what is happening in such kind of situation is there is a drop beat or a extension of the PP interval, which is exactly the double. So in such kind of scenario, this happens in SA exit block. So if you look at this ECG carefully, there is an intermittent drop in the P waves in between the normal sinus rhythm. And if you look at the PP interval, it will be exactly the double of the preceding PP interval. So when you have the exact multiple of the preceding PP interval, so it is usually seen in SA exit block. So if you look at the theoretical aspect of the AC nodal disease, the SA node actually is consistent with 2 groups of cells, the P cells and the T cells. The P cells, which actually are situated right in the middle of the compact SA node, they are the source of impulse generation. Then the T cells actually conduct this impulse out of the SA node into the atrial myocardium. So the sinus node dysfunction can happen either because of the failure of the P cell to produce an impulse that commonly manifests as a sinus pause or a sinus arrest. So when you are dealing with no P wave, that is probably the sinus node is not generating any kind of impulse. But if the T cells are failing to conduct that impulse generated by the P cells, then you get an SA exit block. So there is a generation problem and there is a conduction problem. So these are the two main things that can happen in a sinus node dysfunction. Now, if you look at the AV node, you can pretty much diagnose the first degree, second degree, and the third degree AV block. But in a SA node, because we do not have the advantage of two waveforms like the P and the R that we have in AV node, we practically cannot diagnose any kind of delay that happens in the first degree AB block. Similarly, the first degree SA block, where there is a delay in the impulse generation, we cannot diagnose by a surface ECG because we don't know the exact duration or the time of the P cell getting depolarized. So first degree AB block, we don't diagnose through an ECG. It though can be diagnosed by an electrophysiological study. Now the second degree AB block, that is again like the AB block, we have got two types. So just like the AB block, where in the type A, there is a Venky backing happening around the AB node, here the Venky backing is happening around the SA node. So we will have some kind of group beating because of the progressive lengthening of the interval between the impulse generation and the transmission. So when there is an impulse is formed and it takes some time, if you look at the ECG, there will be some kind of cluster of the QRS complex coming in at one side. So that is called an group beating. So if you are having some kind of ECG where you see the QRS complex are coming in a regular interval in a ECG, and then there is some kind of pause or some kind of delay, so there we have to suspect this type 1 AB block, SA block. But if we look at the type 2 AB block, SA block, similarly just like the AB block, there will be an intermittent drop in the P waves. So you may not get any kind of group beating here, but intermittently you will fail to notice a P wave because that is not conducted out without any Venky backing in the SA node. So the whole electrophysiological principle of SA block and AB block are pretty much the same. The only difference is the first degree AB block we can identify in the ECG, the first degree SA block we cannot identify in the ECG. So what is the pattern of conduction in the SA node? So it is almost identical as I told you. So the only difference in this kind of situation is we have to look at the PP interval rather than the PR interval. You look at here, in a type 1 SA block, I mean it is the SA block type 2. Here there is a group beating here, then there is a absence of the P wave. So there is a gradual shortening of the PP interval, and when the PP interval becomes the shortest, then you will have the drop beat. Just like the opposite of a Venky back that is happening in type 1 movies AB block, where you have the maximally Venky backing AV block followed by a failed conduction. Now here, what is happening? If you look at here, do you see any kind of P waves? We have P waves in between, but there is an extremely slow ventricular escape. So in this kind of situation, suppose there is a P wave, we believe that this is a P wave, it looks like a P wave, but I'm not very sure this is the P wave or not. It may look like a P wave. So the sinus impulse probably is not getting conducted, and that is the reason we have a very slow ventricular escape rhythm. Suppose you see an ECG where you don't see a P wave and the ventricular escape rhythm is extremely slow. So that is usually not because of an AV block, but this is because of a sinus arrest, or called as a third degree SA block. But if you are able to see a P wave and the QRS complex is extremely slow and there is some kind of dissociation between the P and the QRS, then probably it is an AB block, third degree AB block. So what are the causes of the sinus node exit block? So as I told you in the first case, suppose there is an increased vagal tone because of whatever reason, the patient can have a sinus exit block. So when we are talking about a sinus node dysfunction, so they are pretty much termed as a sick sinus disease because there is an abnormal function of the sinus node. So we must understand what are the various spectrums of the manifestation of the sick sinus disease. So if you look at a patient who is extremely bradycardic without any reason, so that can be a sick sinus disease. So mostly because of n number of reasons, the patient can have a sinus exit block. So we have to see what kind of condition actually is giving rise to that. So in a sinus node dysfunction, what you are going to get is, we can get extreme bradycardia, we can have a sinus arrhythmia, which will be non-respiratory kind of pattern in elderly particularly. We will have various grades of SA exit block. And when we are talking about an arrest, SA arrest, the pause has to be more than 3 seconds. We can have atrial fibrillation with a slow ventricular response. Now you will ask me, in a atrial fibrillation, how you are going to assess the sinus node function. So typically, despite having an atrial fibrillation, if the sinus node is functioning well, there still can be a good ventricular response. But if the sinus node is dead, most of the time, this atrial fibrillation patient will have an intrinsically slow ventricular rate. But it will be extremely difficult to tell whether this slow ventricular rate is something because of the AV nodal disease or something related to drugs, dyselectrophilia, and so on. And many a times, a sick sinus disease will manifest as some kind of re-entry in and around the SA node, giving rise to a very fast heartbeat and followed by a extremely slow heartbeat. So there are various spectrums. This is a patient who is again elderly, hypertensive diabetic, who actually had a PCI to RCA for an acute ST elevation MI many years back. She feels occasionally dizzy but she never passed out. She was referred for evaluation, and this is what we got during an Holter monitoring. So what you are seeing here, do you see a P wave here, P wave here, and P wave here? If you look at these three QRS complexes, the rate is definitely slow, but what is happening here? Do you see any kind of P wave? No, we don't see a P wave here. So there is a prolonged sinus arrest. And when we have such kind of sinus arrest for more than 3 seconds, then we should be really skeptical about the further management. So we need to do something for these people. Now, this is another veteran with a coronary artery disease and prior PCI to LAD. She feels extremely tired and occasionally short of breath and palpitation. She was referred to our clinic for further evaluation, and the 24-hour Holter looks like this. So if you look at this ECG, what you can think of? So if you look at the PP interval and the PR interval, they are pretty uniform, right? So I marked those. And if you look at the PP interval, they also are quite regular. Then when there is a P wave which has not been conducted down, that follows a resumption of a normal sinus rhythm. So what is happening here? Now you will argue why this is not an SA exit block. So we told that to call it as an SA exit block, we need to have this PP interval and this PP interval should be exactly the double, but here we are getting a P wave and it doesn't look like a double, it is a sinus P wave which is not getting conducted. So if you look at the morphology of the P wave also, they look quite sinus. So this is the sinus P wave which is generated but failed to conduct to the ventricle. So it is a 2-to-1 AB block. Now, this gentleman who had a coronary artery disease, extremely old person, now this thing we got it in the Holter. And if you look at the timing of that Holter, I don't know what's the time. Yeah, so this is midnight, 45 hours. So this lady actually had this particular rhythm in the midnight. So when she was sleeping. So These are the kind of common Holter abnormalities that you'll come across when you are doing an Holter. And when you see such kind of thing, that you need to scratch your head whether I should mention this particular electrophysiological abnormality as something significant or physiological. That is the reason we must understand the physiological problems that happen so far as the rhythm is concerned when the patient is sleeping, deep sleep, or with some drugs. So if you look at the normal physiological changes that can happen in the Holter is, you can expect a sinus pause of more than 2 seconds in 10% of the people. You can anticipate a sinus bradycardia with a heart rate of less than 40 beats per minute in close to around a quarter of patients. So suppose you are identifying a heartbeat of 34, 35, then you should not be worried. But if you are seeing an extremely slow heartbeat, then you need to evaluate further. So what is the cause of such a kind of extreme bradycardia in the night? First degree aortic block is commonly seen about again 10 to 15% of the patients, and Venky back second degree aortic block is also quite common in 10 to 15% of the patients. So these are the common kind of heart blocks or bradyarrhythmia that you can see during a normal Holter monitoring. Now, this is a patient who has an unrevascularized coronary artery disease with paroxysmal atrial fibrillation. She complains of paroxysmal palpitations and feeling of dizziness, and she was referred to us for further evaluation. And the 12-lead ECG was actually negative. We did a transthoracic echo. It was having a structurally normal heart with a preserved ejection fraction, and the 24-hour tracings was something like this. So this is the pattern of ECG that you commonly see in patients with a sick sinus disease. So if you look at the two components of this ECG, we have something extremely slow heartbeat here, and there is an chaotic, maybe some irregularity in the RR interval that I'm not so sure about, but certainly I'm not able to identify any kind of P wave. So this P wave probably is not a sinus P wave because it can't conduct with such a small gap and producing a QRS. So I will appreciate this particular rhythm, probably an atrial tachycardia, which terminates, and this is the sinus P. Again, the patient had some PAC, then had a sudden bradycardia, then again had a sinus rhythm, then again that same chaotic rhythm started. So this is the common kind of ECG finding that you see in tachybrady syndrome that you commonly to, diagnose. So when you are discussing about a sick sinus disease, we have a whole spectrum of the problem that can happen in sick sinus, starting from an extremely slow sinus bradycardia to some from SA exit block, SA arrest, and tachybrady syndromes. Now, the same patient had this Holter last year, and I happened to actually be there. So, if you look at the preceding QRS, where the QRS is decently regular, you just see some kind of waveforms undulating, maybe if some kind of flutter waves or maybe some kind of atrial fibrillation going on. And if you look at this RR interval, they look pretty regular. However, in 2 beats, it is very difficult to say it is regular or irregular, but certainly this atrial fibrillation was going on and it stopped, and prolonged pause, giving rise to a sinus beat. That means the atrial fibrillation is terminated here. So this is called an offset pause. And I calipered this essay plan, is the longest RR interval, and it came out to be 3.84 seconds. So what do you do? So this is my calculation I have made. So Will you be worried about this? I think many people will be worried about this. But what is the cause of this pause? The cause of the pause is this red guy. If this red guy would not have been there, then this patient would have been having a sinus rhythm like this. So I need to treat this rather than this. So in an offset pause, if it is more than 5 seconds, I'll be really worried because I will think that this patient, whether I treat the atrial fibrillation or not, this patient has an underlying nodal disease. So if I'll diagnose an atrial fibrillation with an offset of more than 5 seconds, that means probably I'm dealing with a significant nodal disease. This kind of offset pause can be there. Now you'll ask me why this kind of offset pause happens. Look at, in atrial fibrillation, the atriums are in a chaotic electrical activity, and the rate of that electrical activity is somewhere around 350 to 600 beats per minute. So when the atrials are beating at that fast rate, although they are not so strong, but the SA node actually thinks that somebody is doing my job, let me keep quiet. But when the atrial fibrillation stops, this guy should wake up. But this SA node is still sleeping. So this happens in a lazy sick sinus disease, either maybe because of the drug or intrinsic disease of the SA node. So we have to be very, very cautious when we are dealing with such kind of pauses following in atrial fibrillation, which is terminated. Now, this guy came a couple of years back to me. He was referred by a cardiologist who saw that patient is passing out. The parents were too apprehensive. Happens to be from a very, very wealthy family from our city. This boy was referred to me for a consideration of a pacemaker. And he's just 16 years old boy and very, very, very athletic. He actually had an acute pain abdomen and he was quite nauseous. And during that time, this gentleman actually advised an Holter test. So to his utter surprise, he got this. So what is happening here is, if you look at the top tracing, it looks decent here. Suddenly becomes slightly bradycardic, 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 and here what is getting delayed? The P or the QRS or both? Again, both. Here the PP interval and here the RR interval. So here if you look at the PP interval, PP interval, PP interval, here the PP interval is prolonged. So SA node is getting affected. Now look at our TR interval. TR interval is pretty normal. So there is no block in the AV node, but the ventricular rate again has come down. Maybe because of the decrease in the sinus rate. So this patient actually is having an effect both on the SA node and the AV node. So in a vasovagal effect, you can see everything depending on what is the intensity of the SA node or the AV nodal function which has been affected. So you can see a prolonged PR, you can just see simply a significant sinus bradycardia, or you see there is a prolongation of the PR interval as well as the PP interval. Now coming to the AV node. Now coming to the AV blocks. So these are all very common AV blocks that we all know about, because SA node is something slightly more critical because we fail to understand the exact interpretation of the ECG, how we can actually identify this population. AB block, like this is a elderly patient with calcium channel blocker and CCBs, and he presented with this ECG. So if you look at the PR interval, it looks pretty long. So this patient has got a slow ventricular rate, maybe because of the beta blocker, and there is a prolongation of the PR interval. So this kind of prolongation of the PR interval is commonly seen in first degree block. We don't have to go into detail and discuss about it. So when you are having a PR interval which is prolonged, it is a first degree block. And there are many reasons for the first degree block to happen. So we all know that some kind of increased vagal tone that we discussed, people are athletically very well trained, improvable infarction, mitral valve surgeries, myocarditis, and some kind of dyselectrolytemia, and commonly used AV nodal blocking agents like the beta blockers, calcium channel blocker, they can actually prolong the PR. And it can also be a normal variant in many people, particularly in elderly population. Now, when we are dealing with such kind of AV blocks, I'm not talking about the first degree B block. I'm talking also about the second degree B block and the third degree B block. This is a very common article that I always quote. So once you are having a drug-induced atrioventricular block, what do you think? Whether the drug is causing the block or the patient has some problem in the conduction on the AV node that is causing an exaggerated response of the drug. So that is the reason we commonly see, if you look at this particular article, they have shown this. So the whole idea of this is atrioventricular block is commonly related to drugs. That means if you are seeing an AV block, there is a possibility that this offending drug might have precipitated that, but it doesn't precipitate in a normal person. That means the AV nodal blocking agents are commonly related to the drugs, but are rarely caused by it. So it is merely the presence of that drug which has worsened the situation. So you have to have some kind of AV nodal disease. And it has been seen that many of these patients who actually resolved after taking out the beta blocker or the calcium channel blocker, thinking that it is causing it, close to around 56% of the patient actually came back with a heart block without the medication. So you need to see these patients over a long period of time, how they are doing. So you have to closely observe this patient. It is not that once you stop the beta blocker or calcium channel blocker, they may not progress the disease and precipitate with some kind of syncope sometime later. Now coming to, there are two patterns of AV block. One is the Venky back phenomena and another is a Haze phenomena. So when we're talking about the Venky back phenomena, so this is a young boy, I'm a middle-aged person who came for a ligament tear operation, and in the PAC, the anesthetist looked at this ECG. So certainly there is a prolongation of the PR interval, but intermittently the P is not getting conducted.
Recording stopped.
So are we, our time is off or what? Hello?
Let's to continue, sir.
We can continue, right? For maybe around 10 minutes or so.
Yes.
So here, if you look at, there is a significant prolongation of the PR interval, which is gradual, and reaching a max of 360, then it drops. So there is a serial prolongation of the PR interval, and this is a common function of the AV node. And the PR interval will be longest immediately before the drop date. Suppose this is the PR interval, it will be the max, and then the P will drop out. It will not conduct down to the AV node. And once the drop bit is there, then the first PR interval will be the shortest because it has resumed its original function. Then it will slowly Venky back again.
Recording in progress.
Now coming to the mechanism of this kind of block is, These Mobius type 1 block are usually reversible conduction block. If you look at the AV nodal cells, they have a property like this, and when that is exaggerated, or the AV nodal function, AV nodal cells actually gets fatigued during the process of conduction, then they fail to conduct. So this is usually a reversible conduction block, but not 100%. But if you look at the cells beyond the AV node, that means the His-Perkins system, they don't fatigue, they just die. Then that regain. So if you are having a gradual prolongation, that means we are having some problem in the AV node. Suppose you are having a drop bit without any kind of PR prolongation, that means we are dealing with a problem with the His-Perkins systems, producing a type 2 Mobius block. See here, if you look at here, so this patient is actually having intermittently the P waves are not there. So there are 5 bits of P and 4 bits of QRS complex, that is a 5:4 conduction ratio the patient is conducting. And intermittently, one of the P wave is not getting conducted. So this Venky back pattern can have such kind of pattern during the block. Then in this kind of situation, where is the block? Where there is a fixed pattern of block, whether it is still in the AV node or it is below his bundle. So it is again in the AV node because it is Venky backing pattern. So if you look at here, there is a slowly Venky backing and intermittently there is a drop bit. The P is not able to conduct. So we can see such kind of Venky backing pattern in acute imperial MI, and that can be produced because of some kind of increased vagal tone called the basal reflex. So these kind of blocks are actually self-limiting. They usually reverse back. You don't have to wait and watch. Now, if I'll ask you, these are the type 1 AB block or type 2 AB block? That we'll discuss later. Now, what is happening here? This is a patient who actually had a mitral valve surgery, and there was an atrial epicardial pacing where we are pacing the atrium and it is conducting with some delay to the ventricle and getting blocked at times. So it is a type 1 Venky backing during atrial pacing. That can be normal. Now coming to the second degree AB blocks, which is otherwise known as a Haze block. As I told you, these are the blocks that happens mostly infranodally. So this is a middle-aged person who actually has occasional skip beats and never had any kind of disease spells in the past, but feels lightheaded sometimes. His ECG was like this. So if you look at here, the PR interval is constant, and in between there is a drop beat. That means there is no pattern of prolongation of the PR interval. That means there is no Venky backing in the AV node, but at times the P is not conducted down to the ventricle. That means there is some kind of block which is happening abruptly. So in such kind of situation, you have an intermittently non-conducted P waves without any kind of preceding progressive prolongation of the PR interval or Venky back in the AV node. So these are the blocks that can happen below the AV node. So as I told you, in type 1 Mobius, there is a Venky backing happening. That means the AV node is getting increasingly fatigued, and once they are completely tired or dead, they don't conduct. But in type 2 Mobius, they are fine, they are conducting well, and intermittently they fail to conduct. So these are the problems in the His-Perkins systems. So they are usually a manifestation of an advanced or an irreversible AV nodal disease. So when we are talking about the AV nodal disease, means the His-Perkins system is also a part of that. So in Mobius type 2, either it will conduct or it will not conduct. So there is an unexpected decrease or stoppage of the AV conduction. That means it is a slightly more advanced disease, and these are the patients who actually has a disease distal to the bundle of His, and they can have associated broad QRS complex because of the progression of the conduction system disease down to the bundle branch. So there are many causes of the type 2 Mobius block. So it can be because of a part of the idiopathic or sclerodegenerative disease of the conduction system called the Langer's or the Leb's disease, or it can be a manifestation of certain kind of drug toxicity, autoimmune phenomena, inflammatory disease, and so on. So we need to identify what is causing this. So what is the clinical significance of this type 2 blocks is they can go into third-degree AV block or complete heart block. And sometimes they can be hemodynamically unstable. And because of the suddenness or unexpectedness of this block, though they should be categorized almost like a complete heart block. And if you look at a type 2 Mobius block, so the systolic arrest is close to around 1/3. So you have to put a pacemaker in such kind of situations. Now there is another pattern of AV block which is called the fixed ratio block. The fixed ratio blocks are second degree AV block with a fixed ratio of the P and the QRS complex like 2:1, 3:1, 4:1. So when we look at such kind of ECG like this, where it is a fixed 2:1 AV block, where there is a 2 P waves and a 1 QRS complex. So whether these kind of blocks are really dangerous? Yes. Suppose we have a high grade AV block, that means it is almost going to block out any time, like it is an advanced disease. So if you are getting something more than 3:1 AB block, that means we are dealing with a high grade AB block. So they should be taken very seriously. So this is the 4:1 AB block, like 4 P waves and 1 QRS. So these are called the high grade AB blocks. So in such kind of situation, your escape rhythm or the ventricular rhythm will be extremely slow. So whether it is a Mobius 1 or Mobius 2, that we need to identify whenever we come across an AV nodal block. This will just skip. So as we discussed the high grade AV block, when we have more than 3:1 AV block, then we need to categorize that as a high grade AV block. So they should be taken with utmost caution. And third degree AV block, we all know there is a complete AV dissociation, that the A is marching of its own and the QRS is marching of its own, and there is no relationship between the Q and the P. That means there is a complete dissociation of the AV nodal conduction. So the sinus node is generating the P wave, and the infranodal conduction pathway is actually creating the QRS complex. So this is a young boy who actually came to the clinic with this kind of rhythm. So here if you look at the thing that the PP is marching of its own and the QRS is completely dissociated. So if you look at such kind of young boys coming with the congenital heart block, the reason for telling you this is, if the infant has a structurally normal heart with a ventricular rate of less than 55, or if the patient has a structurally abnormal heart and the ventricular rate is less than 70, or if the child is beyond the first year of his life with an average ventricular rate of less than 50, then this is an indication for permanent pacemaker implantation in congenital heart block. And in elderly, if the patient has got a recurrent syncopal attack, and with this form of ECG, where the escape rhythm is extremely slow, you just look at the escape rhythm. This is a right bundle branch. Sorry, let me just. So here, if you look at the P's are coming at its own, and the escape rhythm is coming somewhere from the right bundle. That means there is some kind of progressive disease beyond the AV nodal junction. That is the reason the escape rhythm is right bundle. So such kind of complete heart block, if you look at the previous ECG, they can have some kind of fascicular block patterns that we'll discuss later on. So if you look at the complete heart block, so there is a complete absence of the AV nodal conduction. And to maintain the hemodynamics, there will be some kind of escape rhythm which may come from the junction or from the ventricular escape rhythm. So that all depends on how far is the conduction system disease below the AV node. If from the below AV node it is conducted, if it is the disease is quite far off up to the apex of the heart, then you will have an extremely slow ventricular escape rhythm. So it all depends on what is the level of the block. And as we discussed, this is actually a extension of the type 2 AV block. So there is a disease below the AV node. And there are many reasons for this complete heart block, like idiopathic degeneration, digoxin toxicity, and many other hyperkalemia, and so on. So these are the block pattern that we see in imperial myocardial infarction. So this is a complete heart block with a very extremely slow heartbeat. So this is because there is a very, very progressive conduction system disease below the AV node. So this is a complete heart block with probably a better escape rate. And if you look at the P waves, they are almost marching along with the QRS. So these are the kind of when the P and the QRS are dissociated, but you almost see the P waves and the QRS are completely matching to each other. Sometimes it is before the QRS and sometimes it is after the QRS like this. So this is commonly seen in isoarrhythmic dissociation, which is also a normal kind of pattern. So we'll stop here till the next month. So we'll try to again squeeze it down to 40 or 45 minutes so that we can have a meaningful interaction. And if we could not interact today, and if there is some kind of doubt, then probably next month we'll discuss all those things. Thank you.
Thanks, Dr. Rajat, for this interesting session. And it was really, the kind of cases you have shown, it was really good, sir. So there are a few questions in chat box, so I'll take one or two out of that. So there is one question from Dr. Hasnan Sayed that, do we need any treatment in SA block?
So in SA exit block, do you need any kind of treatment? So when you are talking about a treatment means, you are meaning a pacemaker, right? So in SA nodal dysfunction, so how I talk about these SA nodal diseases, I tell them as the SA nodal dysfunction or SAND. So this SAND actually has a various spectrum as we discussed in this module. So it can be just a delay in a SA node function to some kind of exit block pattern where the patient usually do not have any kind of symptoms. The patient only will have symptoms if there is a sinus arrest. So if the patient has a sinus arrest, we need to identify why this patient is having a sinus arrest, whether it is because of some kind of atrial fibrillation, which is causing an offset pause. If the patient has an offset pause because of atrial fibrillation, like many a times you'll see, you are having an atrial fibrillation patient and you are giving a amiodarone injection, and suddenly the patient blacks out and has an extreme bradycardia. You really don't know whether it's the amiodarone effect or whether the atrial fibrillation spontaneously terminated, giving rise to this kind of extreme slow bradycardia. So in such kind of situation also, if I am not having an offset pause of more than 5 seconds and I am not contemplating any kind of rhythm controlling strategy in this patient, probably I will stick on a pacemaker in this. So these are the only extreme kind of SA nodal disease where the patient has symptoms and patient has a significant pause of more than 3 seconds in sinus rhythm. Probably I will think of giving them a pacemaker. Suppose there is a young boy, very young boy, who has a pain abdomen and he is going into multiple or recurrent syncope because of a vasovagal effect. Now, the patient's parents will be really concerned. You can't actually stop this kind of pain abdomen or those kind of intercurrent illnesses ever. But this boy, who is very young, is very prone for such kind of problem. I mean the SA nodal block. And the reason for this SA nodal block is a vagal problem. So nowadays, in such kind of vagal mediated bradycardia, we still do some kind of ganglion ablation. So these ganglions are actually identified both in the RA and the LA, very close to the AC node and the pulmonary veins in the left side. And a careful mapping of these ganglions and ablation are helpful in certain subset of patients where you can't help it. Because the patient is so symptomatic, super symptomatic, and you are unable to treat those kind of triggers. So in such kind of situation, probably they may be of help. So this has been tried in vasovagal syncope as well, where the mechanism of action is pretty much the same.
Yeah, yes, sir. So there is another question in chat box from Nadeem, that drug causing first degree AV block like beta blocker, when to stop and what, and will that be beneficial?
Now, as I said, like the drugs may cause first degree B block, and we all know the first degree B block is not a meaningful heart block. It is merely a prolongation of the PR interval. So if you stop it, doesn't necessarily mean that the AV nodal conduction will completely recover. But this first degree AB block are not going to have any kind of symptoms. So if you can carefully observe the patients, because Nadeem is going to give beta blocker only for his coronary artery bypass surgery patients. So beta blocker will be more helpful for him rather than stopping it. So I will carefully observe these patients and see. Now, if this boy who had a first degree AB block because of 100 milligram of metoprolol suddenly comes with a bradycardia of 38 beats per minute and complete heart block, then we stop the beta blocker. Then what do you do? Now you have to be very, very cautious. Why this boy? I have given 100 milligrams of metoprolol to so many patients, but this particular person actually is killed by this beta blocker. So we need to identify whether this person has got an intrinsic disease of the AV node or not. And we carefully monitor them. Sometimes you'll see that the heart block has completely recovered and patient doesn't come back for many years, but eventually the patient will have a progression of the disease and may need some kind of pacemaker. So you must understand that wording that I told, that the AV nodal disease are AV nodal drugs, blocking drugs are commonly related to the AV block, but they are not usually the cause of that. The cause is something else. The cause is the disease, underlying disease of the AV node.
Thanks, Dr. Rajat.
But I
So,
hope this statement should not convert into excessive pacemaker implantation in certain patients where AV node block has been related to the AV nodal agents. So we must wait and watch. The whole meaning is that.
yeah, absolutely right, doctor. So I would like to say thanks to you for this session. So you give your time from your busy schedule.
Of course,
And
I will just appreciate if the participant actually gives me some kind of feedback through our mobile or through this wherever, so that if we are actually falling short of their expectation or they need some kind of change in the strategy or they want to interact more by some kind of polling or the patient means audience response pattern in the next classes, we'll do that. And we'll try to restrict the talk to 45 minutes and 15 minutes should be discussion.
right, right. Surely in coming session, we will be taking care of all the things and we'll make this session more interactive, like as you are saying,
Yeah.
doctor.
I will try to put some kind of audience response thing so that we can actually interact with these people and we try to take feedbacks and then we do that.
Right. Thanks, doctor. And once again, I want to say thanks to the audience for giving their time also. And I'm sure that everybody is, safe at their places. We'll see you in next session. Thank you and good night.
Bye-bye.
Recording